everyone, and welcome back to OE Headlines, Ortho Evidence's new podcast show where we discuss trending topics in orthopedics and evidence-based research. My name's Abby Payne, and I'm joined in studio today with Dr. Mohit Bandari and Dr. Brad Petrosor. Brad, welcome.
Hello. So what's up with you these days, Brad?
Oh, not too much. Just had a long weekend. What about you?
Nothing new.
Anything? Nothing at all?
No, nothing.
I see you're holding something. What is it?
Oh, I'm sorry. I was just this is great bedtime reading. Like, it's short, several hundred pages.
Right.
Is that what you read this long
edited by
weekend?
yours truly and many other amazing people, hundreds of amazing people. And, Brad, if you don't have one, you just go to Amazon.com and you type in evidence-based orthopedics. Or you can go to Indigo.com. Or you can go to Wiley Publishers and get your very own book. Like, look at this. Yes. Anyways, it's a good book.
Nice.
Pretty proud of it.
Congratulations.
I'm really happy. I should probably make a note, just to let you guys know that the associate editors here were included, lots of great people, Rudolf Pullman, Emil Shemich, Ernesto Guerra, Ashish Bedi, and Moin Khan, and our managing editor was Sepper Thierry, who's been working with us at McMaster University, and many hundreds of exceptional writers and contributors.
I'm wondering if a click, like, and follow for the first one may get a signed copy.
Oh my goodness. I think we can arrange something like that.
So you are writing checks. that I will.
I
Yes.
just clicked, liked, and followed.
Click and follow. Sure. Good luck finding me, but yes, sure.
So we have an exciting show ahead and are going to kick things off as usual with our OE headliner story. Following that, we'll dive deep into the Fast 5 stories that are trending within the medical community today. So first up, we have new clinical practice guidelines have been published in the BMJ for medical cannabis use for chronic pain. And we have the senior author of those guidelines joining us remotely today to discuss. So I'd like to welcome Dr. Jason Bussa, who's the Associate Director of McMaster's Michael DeGroot Center for Medicinal Cannabis Research, as well as the Associate Professor of Anesthesia at McMaster University. Dr. Bussa, thank you so much for joining us.
Jason, I can't thank you enough for giving us some insight. So let's start off with this British Medical Journal rapid recommendation entitled Medical Cannabis or Cannabinoids for Chronic Pain, a Clinical Practice Guideline. Can you tell us a little bit about this particular guideline and what went into getting it ultimately to publication?
Yeah, so this is a topic of considerable interest both in Canada and abroad. So as you know, in Canada, the use of medicinal cannabis for chronic pain has been increasing fairly exponentially over the past 5 years. There are now close to 400,000 Canadians that are registered by Health Canada to use medical cannabis. There are a lot more than that are using it without formal authorization for therapeutic purposes. And at the same time, there's a lack of clear guidance. Healthcare providers are not trained during their education to manage this type of product. And so there's a real information gap out there. And we know from organizations like the Ontario Medical Association, this is one of the leading topics that their members are interested in getting more information on. So we undertook a rapid recommendation, as you mentioned. We conducted a systematic review of all randomized trials on the topic. We looked at observational studies to understand long-term and infrequent harms, systematic review of patient values and preferences, and a review looking at the possible role of medical cannabis in helping chronic pain patients reduce their use of opioids, which you were kind enough to help out with. We looked at all this evidence together with our panel, 21 members. It included methodologists, clinical experts, and our patient partners who lived with chronic pain to make a recommendation based on that evidence and our knowledge of patient values and preferences.
So there's been so much around cannabis, pro and con, around, various perceptions and groups that have, either they're in favor or they aren't. What did you ultimately find? And did you find that there is value in cannabis overall? And can you explain a little bit about practically how someone would use this particular guideline?
Yeah, so cannabis is a tricky product in the sense that it's not a single drug. It doesn't have a drug identification number unless it's a synthetic. So in many cases, it's not prescribed, it's authorized, and then patients will get what they get. So what our recommendation was, after looking at the evidence and our understanding of patients' perspectives, we landed on a weak recommendation in favor of offering a trial of non-inhaled medical cannabis for chronic pain if patients are not satisfied with their current treatment. Now, the reason we made a weak recommendation is because we found very small benefits attributed to the use of medical cannabis. We found there was about a 10% risk difference in favor of achieving an important amount of pain relief. So that means you have to treat 10 patients versus placebo for one to notice a benefit. Benefits on sleep were smaller than that, a risk difference of 6%. Got to treat 17 patients for one to see it. And on physical functioning, smaller than that still. Our risk difference was only 4%, meaning you have to treat 25 patients. We found no benefits on social functioning, mental functioning, or role functioning. There were a number of adverse events that were associated with medical cannabis. Again, very, very small risk differences for most of these, around the order of risk differences of 2 to 5%. Things like sedation, cognitive impairment, temporary nausea. So again, we found there was evidence that there were some modest benefits. It won't work for most patients, but it seems to be helpful for a minority. We also found evidence of modest transient increased risk of certain harms. Again, it doesn't seem as if it will harm most, but for some it will. So because of this very close trade-off, we made a weak recommendation to provide this information to patients and allow them to make a decision consistent with their context and values and preferences. Regarding practical application of this, we are suggesting that clinicians explore a CBD predominant product initially. Again, not inhaled forms. None of the randomized trials looked at inhaled forms. And if patients see a partial response, they might want to try increasing the amount of CBD. If they still don't receive a satisfactory response, we've suggested clinicians may want to then look at adding some THC to that mix and seeing if these patients might be one of the minority that will achieve a benefit. Again, monitoring on a monthly basis, consideration of past use of cannabis. These things will also be important to tailor to the needs of the individual patient.
Yeah, that's extremely helpful. So, I mean, the reality is where do you think it fits in? So you said when they've exhausted or when patients feel they have exhausted other treatments for their chronic pain or their non-cancer pain in this particular case, where do you think it fits in? I mean, clearly, given the amount of interest in cannabis over the last, I'd say several years now, but really heightening over the last few years, there does seem to be just more awareness, clearly more popularity, and I suspect more patients specifically in COVID, it seems more so than ever, have been looking at this as an option. I mean, is this an upward trend you anticipate will ultimately level off or will continue to grow?
Well, it's hard to say, but when you have limited information in terms of formal guidance and evidence out there, then marketing predominates, right? You have all the different companies that are producing and selling these products that will then fill that information gap. And they are probably going to be very enthusiastic about the potential for cannabis to treat everything from chronic pain to PTSD to anxiety to sleep to 100 other things you might imagine. So I do think that there's quite a bit of interest. I think that this is sort of the new kid on the block. It's the new flavor. People are interested in it. There's a lot of hyperbole coming out of industry that I think needs to be tempered. I suspect that once clinicians feel more comfortable providing messaging on this product, some of the enthusiasm will probably tamp down. If people are going to their physician for information as opposed to their local bud tender or dispensary person, I think they're going to get a more tempered, nuanced message. But there is going to be interest in it. I think it's something that's probably here to stay. But right now we've got a weak recommendation based on the evidence available. We did make the caveat that more research is needed, and the results of that research could change the recommendation. So it could be that, 2, 3, 5 years from now, once we have better clinical trials, more long-term information, we may not make a recommendation in favor. But given the information we currently have, we've landed on a weak recommendation to provide this as an option to patients who have not found satisfaction with their care without cannabis.
So, are you aware, Jason, of ongoing trials that may help, clarify or add some more signal to noise? And if not, what would be the trial that you believe needs to be conducted?
So there is work that's now starting to happen, but it's been a very difficult road to get there. Unfortunately, in 2018, when all forms of cannabis, all types of use became legal in Canada, both medicinal and non-medicinal, Health Canada had two standards for providing these products. One, which was a lower standard, was for patients to acquire these products from companies. There was a much higher standard they put in place that would allow trialists to test these same products in studies. And what that meant is for the last 2 years, our group that had funding for 2 clinical trials and 7 other groups across Canada were not able to enroll a single patient because you could not find a single manufacturer that was making a product that adhered to the higher standard that Health Canada demanded for clinical trial use. Very recently, that has changed. So we've now gotten permission to do a couple of clinical trials. We're looking at one to see if we might help prevent persistent pain after knee replacement surgery. Another one looking to see if we can help patients with sleep problems that also suffer from depression. And there's a number of other studies that are now just starting to happen. But we do need these sorts of clinical trials to help figure out what is the true effect? What is hyperbole? What are the non-specific effects? And we have a great playbook for this. If you look at the story of Epidiolex for your, treatment of certain types of pediatric seizure disorders, and there was, hypothesis that high concentrations of cannabidiol, which is a non-psychotropic part of cannabis, might help. They eventually did the pilot studies. They put out 2 definitive trials in the New England Journal of Medicine in the last couple of years. This resulted in an FDA-approved cannabis medicine, the first one that they've approved, called Epidiolex. And they did it the right way, right? We now know that this is not first-line therapy for these seizure disorders, but it may be helpful to some patients. We need those kinds of studies for chronic pain so we can be more confident in what in the information we're giving patients.
That's amazing. I can't thank you enough, Jason, for taking a bit of time to share with us, and continued congratulations on the work you're doing, promoting evidence, and particularly helping us, sift through the noise with signal. So we'll make sure that we provide a link to the BMJ guideline, and we hope to look forward to having you back on our OE headlines to chat more about some of the exciting things you'll be doing in the future. Thank you so much again.
Yeah, thanks for having me on.
All right, take care.
Okay, so on to our Fast 5 stories. COVID-19 has had a detrimental impact on access to hip and knee arthroplasty surgery. A study that was recently published in the BMJ set out to examine whether this has had subsequent impact on pre-op opioid prescribing rates for those who are waiting for surgery. A total of 548 patients were included in this study, 260 in the COVID-19 group, and 288 in the controls. For those with data available, the proportion of patients on any opioid at follow-up in the COVID-19 group was significantly higher, 55% compared to 41% in the controls. So Mo, what are your thoughts on this?
Yeah, it just gets back to what we've just talked to Jason Bussa about, which is cannabis has been used or thought to be one of the opioid sparing modalities. And, while the jury's still out on that, it's undeniable that we have an opioid problem. And COVID, because of the length and the challenges with getting access to surgical care, has led to, I think, a crisis or an epidemic within a pandemic. I don't know, Brad, in your own practice, if you noticed just challenges with opioid prescriptions, and I'm not saying that you're giving lots of them out, but in the context of opioid use, do you think it went up?
Well, I think so, anecdotally speaking. And we are giving out opioid prescriptions because that's, it's still fairly standard after surgery, no matter if you're having total hips or knees or trauma surgery or foot and ankle surgery, to get it. But the ultimate goal, though, is to address a multimodal approach where CBD can play a role, and anti-inflammatories, etc. The problem is the multimodal approach requires a communicative team approach to pain medication post-operatively, and that's sometimes a challenge.
The real challenge too. During this, like the heart of the pandemic, so to speak, March 2020 onward, they called it March 11th, the global pandemic, and then through that year, I happened to be, just timely or untimely, the president of the Canadian Orthopedic Association. So we did this movement across Canada virtually, trying to understand the impact of OR shutdowns. And, we had surgeons around the country that were anywhere reduced from, down to 20%, and some were, actually almost halted. And in certain provinces, hip and knee arthroplasty is one example. Trauma, not so much, but hip and knee arthroplasty was basically preferentially stopped because it was considered a lifestyle procedure. Now, paper comes out in the Bone and Joint Journal around March of 2021, looking at 800 some odd patients. Great paper in that it demonstrated fairly convincingly in this patient population that there was 1 in 3 patients waiting for hip arthroplasty and 1 in 4 patients waiting for total knee arthroplasty that would describe themselves having a current situation or fate worse than death. So on a Euro-qualified quality assessment tool, you can rate your current situation as anywhere from +1, which is perfect health, to -1, which would be basically a fate worse than death, or in the negatives. So in this particular case, it was fascinating to me to get a sense of just how much that wait list of patients who suddenly were expecting surgery, were blocked from it, were getting progressively worse. In fact, they had suggested that the compared to controls, pre-pandemic controls, it was double the rate of patients feeling that they were in a fate worse than death. Hard not to imagine that you're going to go for anything that will help you with respect to pain control. And opioids have been in the past sort of one of the mainstays, but the addictive nature and the challenges really warrant us to be looking very aggressively at other treatments for those sorts of therapies, for those sorts of arthritis, hip and knee.
Yeah, for sure. And how much of that do you think was actually fear of unknown, fear of I may never get the treatment, that sort of thing? Do you think, I wonder how much that plays into it as well as just the physical pain but I just wonder how much is I may never get this. I don't know what the future is holding here.
Well, there was a group of people that I like, if I think about it in thirds, there was a group of people that were in absolute agony. And it's a squeaky wheel, so they were just saying, I'm in agony, and they would somehow get through the system because they were unrelenting. And that's appropriate. I'm advocating for myself. There was a group that was simply avoiding, like, I don't want to go anywhere near the hospital because, there's COVID there and I'm at risk and I don't want to take any risk. So they were, and then there's this big chunk, I think, in the middle third, to your point, apathy. Okay, I guess this is my life. I guess I live with this now. Now what? I may never get surgery. And I believe that group primarily started seeking, like understanding, okay, let me look at alternatives. I would have never even thought about cannabis, but I'm going to start looking at cannabis. I'm going to start looking at all these injectables and things that I would never try before. I'm going to try them now, or I'm going to at least learn about them, because that may be my only access to healthcare right now. I'm not going to get surgery anytime soon. So that's kind of where we are. And I don't think that this wave of backlog is done yet, right? If you think about just in that 18-month period, how many cases have been deferred. Now, some may have just been deferred, like, I'm just not going to go back to get surgery. I'm just off. When they say, oh, well, we're publishing unemployment rates. Well, some people, and when unemployment rates go down sometimes, it's kind of artificial. Not some people just stop looking for work. I think some people just said, I'm not going to get surgery. So therefore, my waiting list numbers are altered by that. But I think there is a massive opportunity to be thinking about alternative or standard treatments that have not been non-surgical in a way to really maximize and optimize on operative care in everywhere, in trauma all the way through to sort of in this case the lifestyle areas such as hip and knee arthritis.
Yep, agree.
Yes.
Okay, so this is a perfect segue to our next story. 8 years after the first update, the AAOS Board of Directors has updated its evidence-based clinical practice guideline for treating painful osteoarthritis of the knee. With changes to 19 of the 29 recommendations from the previous guideline, the new document focused only on less invasive non-arthroplasty treatments. So, Mo, I know that you're well versed in this area of evidence. So what are your thoughts on this?
Yeah, I think it was 2012. You said 2013 or 12 when the first ones came out, or the first big ones came out. And I remember, sort of the wave that went out saying, okay, they had suddenly said that, there's no more role for hyaluronic acid, for example, in hip and knee arthritis. But that was just one of the, the talking points. If you look at now, 19 out of 23 changes.
29,
or 29, sorry. So that tells you already that, evidence is moving. And they're also rethinking about, what opportunities we have. I have to believe that panel deliberated very carefully in light of what's been happening, right? We got to find things that work for patients non-operatively. One thing I will say, Brad, you may not be aware of some of these details, but I'm curious on your thoughts on this. So, hyaluronic acid, intra-articular corticosteroids, and PRP all had changes, slight changes to their grading. Intra-articular corticosteroids was downgraded to moderate, so it was a lot stronger. They downgraded it based on, I'm pretty sure, some of the recent studies that had come out in that period of time talking about MRI findings and corticosteroids impact on cartilage. PRP also downgraded 2 times. So it went down from a much stronger to a much less based on what? Inconsistency of the findings. And I've been saying this, I must say, I have been saying this, and the evidence supports this, which is PRP, when it works, it is a dramatic impact. And you see it in terms of the highest, impact of the 95% confidence interval, but it also goes right down. So there's so many formulations that the overall heterogeneity is so high that you have to downgrade it until we get large enough trials that really get standardization. But guess who the winner is? The winner is HA, I think. Now, HA was downgraded from a strong recommendation against to a moderate recommendation against. You say, well, what's so great about that? The caveat is that downgrade is based on one sentence they put in there, and they say, we realize and we appreciate and now acknowledge that there are significant improvements with high molecular weight cross-linked products. So there may, in fact, be in a subset of patients use for high molecular weight. That was always the storyline. It was never that the American Academy was, misguided in this. They were absolutely right. If you looked at all products, all in, the effect is nominal. But if you look at important subgroups, potentially, the high molecular weight historically, well before 2012, still had that signal. And I think they're just recognizing that signal is a reasonable consideration in a subset of patients. So I think that's kind of what I took away from that. But at the end of the day, these are still what are the mainstay injectables that are available. So I think it was timely and important. And I think we really should be made aware of these. And I think what we'll do is we should provide a link to these guidelines, and we'll make sure we provide a link in the notes to this to this particular podcast.
And that's in my standard discussion of so I do ankle arthritis as opposed to hip and knee, and I do replacements and fusions. And this is always in my standard arthritis talk. It is when you're talking to patients, I say, you have 3 choices. You can do nothing and live with it, and we'll try some pain modalities, as we've just talked about. I said there's injectables, and there are 4, in fact, injectables, as you know. And then the alternative is surgery. And then you start describing surgery, and people are like, whoa, tell me about those injectables again. Like, people are, when you tell someone that you are actually going to do a total knee, or in my case, a total ankle or a fusion, people are saying, well, what can I try? And I say, just like you, steroid, just like the guidelines, steroid, HA, PRP, and even stem cells. I bring it up. Why? Because our job is to educate patients on pros and cons, and there's lots of signal, lots of heterogeneity in there, not a pure signal, but you're right. Some people do benefit, and there's a lot of people who say, a couple $100 and I get some pain relief, and you're not going to cut my knee open or my ankle? Okay, I'll try it. And I'm sad to say it, but it's my age patient, right? You know, I'm 52. If I have arthritis, I'm going to say,
I think
try
all
it
of us,
before
right?
you cut my knee out.
Yeah.
I mean, as good, Abby, as good as a total knee replacement is, as good as a total hip replacement is, would you undertake that procedure without exhausting all non-operative options?
No,
Right.
definitely not.
But I can tell you right now, there are lots and lots of individuals who get that procedure without having exhausted it. Now, there's lots of reasons, and you can't just, you can't just generalize it to everyone. But I actually believe if patients are given all the options and the evidence-based options, it would not be difficult to think about at least trying them as a way to temporize.
Well, and our job is to discuss treatment alternatives and pros and cons of each.
Yep.
And this is where we go.
Yeah.
So, question: a patient who is potentially too early for a knee replacement.
Yep.
What would be the recommendation for them in terms of an injectable?
Right, that's a great point. So it depends, because every injectable, and if you just look at these three right here, right, you'd say, okay, well, each has their potential strengths and each has a potential drawback. Typically speaking, when someone has, an inflammation, like a swollen knee, and someone needs pretty immediate or pretty quick pain relief, they would say corticosteroid. And I say they, meaning just the general consensus around that. And then you can see the evidence is moderate. It's not like it's particularly bad. PRP and HA have sort of been in this, I'd say, like the popularity of PRP has skyrocketed, probably a little bit in advance of the evidence following, whereas PRP has been around, whereas HA has been around for a long time. So, but they're generally for early, right? Generally for early arthritis. So you're right. When it gets more severe, by then you can try it. It may not give the same impact, but it's either or on those. And there's combination therapy, so you can do a mix of hyaluronic acid with corticosteroid.
Yeah, for sure. And there's a cost hierarchy as well. I mean, cortisone has been around for eons and is very, very cheap and generally safe. Although, as you mentioned, there are some cartilage potential if you give a lot of it. You don't want to do that. And
so the paper you're talking about is the paper in the paper in the JAMA that was published by McAlinden and colleagues that simply said, if you give corticosteroid injections every 3 months
for 2
years, if you get an MRI, and there's about 20 different MRI categories that they looked at, a couple of them are going to show that there's a significant increase in fibrillation.
Right.
Doesn't necessarily correlate with the plain X-ray, but that has been some of the pause that people have taken. Others would say, I'm not really too concerned about an MRI change in fibrillation when the majority weren't necessarily consistent. So that paper, in many ways, hasn't necessarily scared away people from taking a corticosteroid, especially those in need.
And as more people are using HA and PRP, the price points are coming down as well. And those two formulations are actually very safe. There are risks, of course, in getting an injection in the knee, etc. But generally, the risk-benefit profile is in favor of the product. And a lot of people just say, I want to see if I'm one of those subset of people who are going to respond to this.
I always look at it this way. Remember, we had this discussion about, getting an ultrasound treatment, low-intensity pulse ultrasound for, say, you had a non-union. Well, if you have arthritis and someone says, hey, the downside is actually relatively low, and it may be cost, maybe the downside for the most part, you probably, I would imagine, say, yeah, I'll give it a shot as long as there's a safety profile associated with it. So you'd have to reconcile whether you believe the information and it's being relayed to you about the safety. Yeah. And so that would be it. I think it's our job to make sure that the evidence is portrayed around safety and efficacy, and then you kind of have to make that decision.
And I'd also like to say, just in this discussion, I don't think we're making recommendations right now. We're discussing these points. So if anybody's listening, these are talking points for your practitioner to discuss about pros and cons of all of this stuff.
Yeah.
So,
in fact, all of these require direct communication with patients and looking at values and preferences. EBM always says, right, you look at the best available evidence in context of patients' values and preferences.
Absolutely.
So there is no absolute right answer in this, and a lot of it comes to discussion.
Okay, on to our third story. Merck and Ridgeback Biotherapeutics announced a new oral antiviral medicine significantly reduced the risk of hospitalization or death in adult patients with mild to moderate COVID-19. At the interim analysis, the drug reduced the risk of hospitalization or death by approximately 50%. So 7.3% of patients who received the drug were either hospitalized or died through day 29 following randomization, compared to 14.1% of placebo-treated patients, leaving us with a p-value of 0.0012. At the recommendation of the Independent Data Monitoring Committee and in consolidation with the US FDA, recruitment in the study is being stopped early due to these positive results. So Mo and Brad, what are your thoughts about trials that end early for the cause of benefit?
I have to know nothing about the actual science of what's been happening, but I can tell you there is a lot of debate on whether you should stop a trial early for benefit. Brad, I know you have some thoughts on this, but the first thing I always say and I think about in these sorts of trials is when you're stopping a trial early for a massive effect, you could just, it's the play of chance that you just happen to be, when you look at we talk about precision of effect getting more and more precise as you get more patients. A really wide effect early with a small number of patients, you could be cycling through a huge benefit, right. Or if it's bad luck, you're cycling through a huge problem, right, or harm with it. And over time, you kind of get to the real effect and it kind of narrows down. Mm-hmm. So you could be playing, with chance here around having a chance finding of a large benefit. So I would be particularly interested to understand also, just how many outcome events there were. And I think, did you say how many? Did you say there were about 100, under 100
no,
events?
It's interesting when you mention outcome events because there was 28 in one group and 53 in the other.
Yeah. It's under 100 events, and I can tell you this is going to be work that's been done by PJ Devereaux, Mike Walsh, published in the Journal of Clinical Epidemiology, and subsequently on the fragility in this case of the p-value. I would imagine that the fragility index here would be relatively small. I don't even know. Do you know what it was? Did anyone calculate it? Do you know the number?
I think it was around 8.
There you go. So 8. A fragility of 8, Brad, means?
For the sake of 8 events, you could sway the results.
That's correct.
Depending if you have a change of 8 events.
Right. So if this study was repeated, you probably wouldn't get the same answer, my gut feeling. There's a risk. There's a risk here of concluding benefit. Now, you know why they did it, because they want to get a potential treatment out as quick as they possibly can. I totally buy the idea of potentially stopping early if there's demonstrated harm, because there's real risk there. But for benefit, that you don't necessarily know, because there's been example after example of trials stopped early for benefit that when you actually continue to enroll or subsequent large trials come out, they don't show that same benefit. That's the risk here. It's a decision that's been made. Lots and lots of debate around it.
No, I remember sitting in the audience when Victor Montori was presenting his systematic review and listening to Gordon Guyatt talk about this. It was actually chilling because the swings of the data as the data is accrued, there were trials that would potentially have been stopped early, and had they been, would have had a completely opposite result. And that happens time and time again. But having said that, the argument for doing it is ethically, as you just alluded to, if you see a clear benefit, then ethically you shouldn't be enrolled, you should be treating people with this benefit. But I look back at Victor Montori's and the whole group, PJ Devereaux and Gordon Guyatt, and everybody who was on that study, that review, and the average event rate was 66, which is starting to fall into here. And and the magnitude of effect is...
Sorry, you mean the average RR, the relative risk reduction?
No, the event rates in the trials that were truncated or stopped early was like 66, and we're at 70 here. And we're at a high risk. Now, again, I'm not saying that it's not a true result, because I believe, reading through it, they planned an interim analysis, they planned stopping rules, met the stopping rules, etc. But one has to go through a very rigorous stopping rule to do it, and there's definitely argument.
Yeah, lots of debate here. So we'll see, and I'm hopeful that it does bear out to be as promising as it looks.
Okay, on to our fourth story. A study concluded that early weight bearing after the operative treatment of an unstable ankle fracture was not inferior to non-weight bearing in terms of OMAs, assessed at 12 months after injury. The patient's subjective satisfaction was similar between the groups, although the time taken to return to pre-injury activities was shorter in the early weight bearing group. Brad, what are your thoughts?
Well, there's certainly a move to weight bear people early, and that's been shown by the COTS trial. Neelafar won an award for that trial in early weight bearing. This trial, some of the previous meta-analysis work would suggest that that may not be as strong, as robust, and some of that depends on the ankle fractures that go into it. And it also depends on the syndesmotic involvement and all that sort of stuff.
So-
but there's definitely
So
a
they're
trend.
saying unstable. When someone
Yeah.
says unstable ankle fracture, what does that mean to you?
Traditionally for me, the ones with syndesmotic disruption, so a higher fibula fracture, medial compromise, either malleolar or deltoid, where I need to fix the syndesmosis, those ones for me and a lot of people I think are still delaying weight bearing on because there's risk of hardware damage and significantly osteoporotic fractures that patients with diabetes, you may want to slow down your stuff, your post-op rehab. That's my opinion. As opposed to evidence, but no, there's definitely a move to fix the ones that without syndesmotic involvement that you want to get in weight bearing early. But people are still using an air cast boot or a cast to weight bear these patients in.
Yep. Okay. And that also gets back to starting range of motion, whatever else you're doing early, right? I mean,
Yeah.
early rehabbing seems to be also just an area where you want to get people back to functioning as quick as possible.
Well, with these new trials and the other trials that have been coming forward, it's time for an update and meta, which there may be one. I'm not sure yet.
Right.
It would be worthwhile doing it.
Interesting. What proportion of trauma surgeons do you think right now, who are treating patients with unstable ankle fractures, you think are actually moving to more aggressive weight-bearing protocols, more aggressive rehab protocols?
Yeah, I don't know an actual percentage, but I know that the for instance, the group from Sunnybrook is, and the Toronto group, because they were involved in the trials, and the COTS group are. So I think trauma surgeons probably are moving more towards it. It'd be a total guess, 60-70%.
Yeah, fair enough. Good.
Okay, so on to our fifth and final story. In this trial involving patients who underwent surgery for degenerative lumbar spondy, most of whom had symptoms for more than a year, decompression alone was non-inferior to decompression with instrumented fusion over a period of 2 years. Reoperation occurred somewhat more often in decompression alone in the decompression alone group than in the fusion group. Mo, Brad, what are your thoughts?
First of all, there's such a paucity of high-quality trials, generally out there, but within spine, I think it's really important that we do more trials. And this is, just another example where you're trying to sort out such a complex problem in which you're adding instrumentation, you're doing a decompression. If you look at it in any other area, you're trying to just look at the individual steps and trying to look at the relative benefit. This would suggest that the instrumentation, for the most part, doesn't seem to add any more benefit, although they do say the word somewhat more often, which I have no idea what that means truly. When you think about it that way, it's like saying we did a retrospective or prospective, evaluation of retrospective data or something like that. It's some mishmash of something.
Mm-hmm. Yeah, I mean,
I don't know what to make of that, but I do applaud, anyone trying to conduct trials in an area that is otherwise particularly difficult to do so.
Yeah. No, I agree. This is a spondylolisthesis where there's some potential slip, and the argument is that if you don't instrument them, then you can potentially make them more unstable. But I think also there's a move to more MIS stuff with spine these days anyway, and so those days of doing really big decompressions and leaving it I don't think people are doing that as much. I think people are doing more focal decompressions. Now, I'm not a spine person, but that's what I think may be the reason for this result. The other is it could just be very limited patients, and you're right. They say, there may be more reoperations, so I'd want to have a closer look at the numbers here.
Yeah, and I think the one thing that we often get, you often think that, okay, we should jump to trials, and while I think trials are really important, it's also, I think, really important to understand, that group of patients in which surgery is truly going to be beneficial, and large cohorts of patients, groups of patients in which you evaluate a host of different backgrounds, treatments, and you try to look at outcomes and say, okay, of all these different patients which ones or which features seem to be the most predictive of someone having a poor outcome or a good outcome, and then trying to work and say, well, how do we modify, some of these risk factors, which would be a way to go, because we've done that with trauma recently, and you really learn a lot. Like, we make the best guess in saying, well, we already assume that doing an instrumented fusion is the right thing, so therefore we can try it against doing not. But what if it isn't? What if that's not the right prognostic factor at all? But maybe it's some issue of proper perioperative care. Maybe it's some other adjunctive therapies that we don't think about.
Yeah.
Not saying it's the case in this particular trial, but the reality is I think we do need a much more holistic, multidisciplinary approach, because these kind of problems that are complex are not going to get solved in silos.
Yeah, exactly.
Well, that's it for us today. I'd like to thank our OE community for taking the time to tune in today. We would like to encourage everybody to submit any topics or questions to headlines@myorthoevidence.com. Mo, Brad, thank you again for joining us.
Thank you.
Thank you.
Thank you.
Thanks for having me.